Okay, before we start, I want to thank the staff of the Westin, right? Yeah, I mean, the food was great. They've been terrific. The facilities have been great. And I want a round of applause for the Westin catering staff. Y'all have been terrific. This is great. So thank you very much. This is the third panel of the day, and the title is Receiving Countries Meeting the Health Needs of Refugees. And we probably should have made it Receiving Country, because we're going to talk about one country, and that is the United States, and how we are doing meeting the health needs of refugees. The members of the panel are Curry Kim, who is the Director of the Division of Refugee Health in the Office of Refugee Resettlement, and that is part of the Department of Health and Human Services, right? And so you've come down from Washington. J.D. McCreary is Executive Director of the Atlanta office of the International Rescue Committee.
Yes, sir.
And that's Atlanta, all of Georgia. What's your turf?
Primarily the metro area, but all of Georgia, if we were to resettle statewide. It kind of depends on who comes in.
Okay, and Dabney Evans is Assistant Professor of Global Health at the Rollins School of Public Health, which everybody here knows is part of Emory University. And I run into people every day who are either your students or your former students, and so your fame is widespread. And I'm going to operate on the basis that each of y'all knows how to read and that you will read their full bios, which are here in the program. So, Dr. Kim, let me start with you. First of all, why are you dressed like a Navy officer? I mean, everybody here wants to know the answer to that.
Yes, so I'm a commissioned officer in the U.S. Public Health Service, which is one of the 7 uniformed branches in the U.S. government. Of the 7, 2 are non-combat, and USPHS is one of those. We serve in, a lot of us serve in HHS in health roles. There's many of us at CDC, very few of us at my agency, the Administration for Children and Families, ORR, but we provide epidemiology, medical care, technical expertise to the various agencies within the U.S. government.
That's cool, and you can tell by the symbol there above the stripes, right?
Yes, and this is actually parallels the Navy uniform.
Right.
So although sometimes when I go on airplanes and I don't have a chance to change out of uniform, I have gotten an upgrade because I thought I was a pilot. So that was
now that's
an inadvertent perk.
That's a good deal. That's cool. Okay, so Health and Human Services, federal government, what is your role? I mean, people somehow, who has identified refugees to be resettled in the U.S., and what does Health and Human Services do, and what do you do every day?
That's a great question. There's a lot of misunderstanding about that. The refugee process is kind of divided amongst 3 departmental cabinets, the Department of Homeland Security, the Department of State, and the Department of Health and Human Services. And we heard from Mr. Henshaw with Department of State, PRM, on their role overseas. So they have the responsibility for getting the refugees to the United States, and also during what we call RMP, the initial reception and placement period, 30 to 90 days of making sure through the VOLAGs, like the IRC, making sure that refugees...
And a VOLAG is?
Sorry, I'm very prone to government speak. Voluntary agency, so okay. The VOL and the AG. So there are 9 voluntary agencies with hundreds of affiliates throughout the United States that do the on-the-ground work of resettling refugees in the United States. I'm sure J.D. will talk more about that. And so the initial resettlement period is very intense, and I don't want to get into too much of your lane, but after that period, our funding, ORR, the Office of Refugee Resettlement, kicks in. The framework of refugee resettlement here in the United States is built on economic self-sufficiency and integration. So we have many programs in our office that gives communities and refugees the tools and resources to become self-sufficient. The unique thing about refugees and other groups of people who have refugee-like status in terms of benefits is when they come to the U.S., they are like U.S. citizens in terms of being able to access benefits. For example, Medicaid or other SNAP, food stamps, TANF, welfare, when they first come here.
And people who come as immigrants through the
right,
the standard immigration system.
Right, the legal permanent residents who come, there's a 5-year bar before they can access public services. But refugees, because it's a humanitarian program, we're inviting them in. You need some help. They're coming in, often with nothing. So they need that initial period of assistance. And if they don't qualify based on either family category or half the states have expanded Medicaid, half the states haven't. So in half the states, most refugees are going to get Medicaid, which provides them with ongoing medical care as long as they remain, under the income threshold level. But for half of the other states that didn't expand Medicaid, family units will be eligible for Medicaid, but for single adults or adults without kids, they would not be eligible for Medicaid. So our office funds short-term, right now it's only 8 months, medical assistance that parallels Medicaid, as well as also short-term cash assistance if they don't otherwise qualify for TANF in their home states. And a wealth of other grants and programs that enable refugees to, many of them come with this entrepreneurial spirit that was mentioned. So we have micro-enterprise development programs, IDA, independent like development resources for refugees to start their own businesses. We have a unique program in childcare, so refugee women can start their own businesses in their home, providing childcare. So all sorts of programs like that to enable refugees to become self-sufficient. Our program, our division, the Division of Refugee Health, was established a few years ago with the recognition that health is foundational to successful resettlement. Because if you're not healthy, if you're not well enough to go to school or have a job, then it's very difficult to achieve economic self-sufficiency.
What are the particular health needs of refugees that different from the general population when they arrive in the U.S.?
When they arrive in the U.S., refugees go through a domestic screening, most of them. It's not mandated by law overseas. All refugees are required to undergo a medical screening. Here, domestically, it's highly encouraged, and most of them do as part of the RMP process. And that's really supposed to be the bridge between the overseas to the domestic continuation of care, where health needs that were identified overseas are addressed, and others that may not have been identified overseas are discovered, and then they're referred to further care in the community. Refugees, a lot of their health issues may parallel their country of origin, like other people who are coming from the same country may have similar health needs. So it really depends. When you talk about refugees, it's a diverse group. In the Middle East, for instance, the CDC has done studies that found that many of the Middle Eastern refugees suffer from a lot of the chronic diseases that Western society are also plagued with, obesity, hypertension, hyperlipidemia, things like that. The health issues, for sub-Saharan Africans may be different, more acute infectious diseases, maybe higher on the radar. So there's a lot of health needs to be addressed, but a lot of their health needs are also not that different from what Americans may need, and a lot of their health challenges, while unique because of the language barriers and some of the traumas that they have gone through, still are very have parallels with just Americans trying to access health care. There's not enough doctors that accept Medicaid, so even if they have Medicaid, sometimes just trying to access health care can be an issue.
And the traumatic experience they've gone through, does that is there a special set of mental health issues associated with refugees coming from Syria, for example?
We haven't seen, as it was mentioned, we're trying to bring in up to 10,000 Syrian refugees. We haven't seen as many, so I don't have a lot of health data on Syrians. But I have for the Iraqis, though, who have come. One of the issues we have that we're aware of is the high levels of being victims of torture in their home countries. And our office also runs a Services for Survivors of Torture program that funds over 30 centers of services for torture victims in the U.S., including one here in Georgia, that specifically address that need. Last year, in fiscal year 15 anyway, we served over 9,000 victims of torture. The number one country represented among all the clients were Iraqis. And we know there's going to be high levels of history of torture on the Syrians that will be coming as well. So that's something that needs special attention.
Let me turn to you, JD. So refugees are identified overseas, selected to come to the United States. HHS helps with certain parts of that. And then somebody calls you at some point, sends you an email and says, I've got X number of refugees who are going to arrive in the month of May. Is that how it works? What?
It's not that far off, actually. Our relationship with our clients really begins on paper anywhere from a couple of months to 6 months prior to their arrival, where we do something called provide an assurance, which means we get some basic demographic data, who they are, where they're coming from, family makeup, maybe some health information, maybe some educational or work history, and we say yes. Specifically, the Atlanta office is a good location for this family, and we'll say.
So you choose or they assign?
It's a combination of both, and then we actually have to take a step back. It's decided on an annual basis where we provide what's called an abstract to the State Department, and in that abstract we have to identify and state the capacity, not only for our office but also for the local community or the city in which the resettlement is going to take place. For instance, we're speaking of health. What health infrastructure is there? Is there an existing ethnic community already in place? Is the school district and community very welcoming? Those types of things. So we state that capacity. We're in agreement with the State Department on an annual basis. And then if you have a couple of factors that kind of decide where you'll go in the U.S. The primary one is if you have family or not, if you're what's called a U.S. tie. If you're a U.S. tie, it means you have a family or a family-like relationship. You will be placed at the closest resettlement agency office to where that family lives. So that's a lot of our families come that way.
And how many, I guess fiscal year, U.S. federal government fiscal year, is that how you measure it?
Fiscal year.
So how many did you bring in the last fiscal year and to Georgia, and how many in this fiscal year do you expect?
To Georgia was just shy of about 3,000. And there are 5 resettlement agencies or VOLAGs like ourselves working in Georgia. So that's spread out amongst 5 different agencies. And that mirrors, we were, I want to say, 8th or 9th in number of refugees who came during the year. And we're also about 8th or 9th in population size-wise in the country as well. So it's right in proportion to the size of the population of Georgia.
And how do you decide, so you've chosen, out of this past year, IRC, what countries are represented? This is refugees from everywhere, not from a particular.
Refugees from everywhere. IRC, and specifically because we're based here in Atlanta, Atlanta is a very diverse city, as many of us know. And kind of one of my rules of thumb is if IRC headquarters or PRM has a obscure language, I always say, well, just give me a couple of days. I can find somebody who speaks it here. I just need a couple of days' notice, and inevitably we can find it no matter how obscure it is. But we resettled from about 20 different countries last year, 20 different nationalities, representing about 30 different ethnicities or language groups, and that's primarily when you get into the Burmese and the various ethnic groups and languages is when that really, where you get some of that variety. But we find out about them when they're coming a few months out. Then about 2 weeks out, we get another email that says they're on this flight. And our relationship with our clients in person begins at baggage claim at Atlanta Hartsfield.
And you're settling them primarily in Metro Atlanta or all over the state?
Well, again, it comes down to where the ethnic community is and if they have family. And obviously, if they have family, we're going to put you as close to that family as possible. Sometimes that's in the apartment right next door, but certainly maybe within the same complex, or certainly as close as we can get you.
And what sort of, I mean, I'm asking questions that I should know the answers to since we talked about this on the phone, but I assume that, I mean, services are more intense when they first arrive. I mean, what do you do for somebody, and how do you ease off? I mean, 6 months later, a year later, 5 years later? I mean, at what point do they become completely independent of IRC?
That's a great question, and it varies. Obviously, each family has its own needs, its own goals, its own starting point, shall you say, its own ending. They're deciding their own ending point, wherever it may be. And we're there to support them along the way. We're there to help them wherever their starting point is, and we're there to help them whenever they decide to step off.
And when you help with money, you help with advice, you help with transportation. I mean, what does help mean?
Yeah, all of that. We provide primarily two things. One is the direct assistance, which is the financial assistance piece, which is a combination of Health and Human Services and State Department that provides funding directly to the families based on a per-person basis of how large the family is. So if you're a single, it's not a lot of money. If you're a family of 8, it can be something, quite a solid nest egg to get started. And then we also provide the case management services and the auxiliary services as you go along. So we make sure that the kids are registered in school. We make sure everybody goes to the health screening, which has never been told. I've never been told that it was optional. Which is fine. It's highly encouraged, and we highly encourage it too. We want to make sure everyone gets to the doctor, and that includes the health screening at the Board of Health. And then also your primary care physician, we want to make sure you get there. And then any specialist you might need. Sometimes, when folks overseas have not had access to medical care, some of those chronic conditions can build and they haven't, and they need to go see a specialist when they arrive. We make sure that everyone gets their Social Security card, that you're registered for any benefits that you might have. And then we also provide hours and hours and hours over the course of a couple of weeks of a variety of orientations. Everything that you need to know about how to survive in Atlanta culture and society, of all things. How to use MARTA, which is incredibly complex, by the way, if you're new to that sort of thing. All of those things so that you can be self-sufficient, so that you can do for yourself when you're ready and able to do so. And then one of the more important things that we do is make sure that the adults are seeking employment. And we assist with employment, and we assist with household self-sufficiency. And Georgia has one of the highest rates of refugee household self-sufficiency in the country, and it hovers between 85 and 90%.
Within how?
Within 6 months.
Within 6 months.
180 days of arrival. So a refugee family has gone from all of their belongings in the entire world, we're picking you up at the airport, to within 6 months, at least one person in the family has gone to work and is earning enough to pay the rent, pay the utilities, have some money for whatever their needs might be.
That's extraordinary. So at that point,
it's impressive, and that's the refugee clients, and that's how we're absolutely privileged to work with them.
So
it's
at that
amazing
point,
to see.
you take off the training wheels.
Well, we can, and then obviously some some clients have more needs than others. Maybe there's an ongoing medical need. Maybe there's some school issues. We provide those services as well, where several after-school programs that we have, a summer camp program, so we're trying to assist with youth. We have multiple levels of adult ESOL programming for English services. And one of the unique things about working with our clients is you never really know when it's the last time they'll come in to see their case manager or to see you. They decide for themselves when they're ready to move on, and they may not even know it, that it's the last case management touch point that we might have with them.
Dr. Kim, how common is that?
I just wanted to, I was just thinking when you had asked about the length of services that, and I had mentioned about cash and medical assistance, that's short-term, 8 months right now. But some of the ORR funding refugees can access for ORR is? Office of Refugee Resettlement, through grants administered to the states or VOLEGs are accessible for up to 5 years. And that's mainly concentrated around economic employment, case management, ESL or English as a second language services, all geared towards trying to help refugees integrate and become self-sufficient. I think other panelists have mentioned that refugees, they don't, most of them, they don't want a handout. They need a hand up to make it on their own. And they're survivors. They're really heroes. I mean, they are the ones who have, overcome so much to come here, and so they have this desire to succeed and to make it. And your numbers are awesome, 6 months. If you can just imagine not knowing the culture, not knowing the language, just trying to navigate riding a bus, riding the MARTA, trying to, a lot of American, native-born people have difficulty navigating the health system. And finding economic opportunities in this climate. So to get off welfare or cash assistance in less than a year is really remarkable, and I think attests to the strength of refugees.
Dabney, you've got the academic perspective on this. Emory, one of our great universities in the metro Atlanta area. You're studying this, you're looking at this. How prepared are our institutions to deal with refugees, and how prepared are our academic institutions to contribute to the way that we deal with refugees coming into Atlanta and into the United States?
I think there are two really important roles that academic institutions can play. We heard earlier today from the representative from Hopkins about how important research institutions can be in terms of gathering data, and that is a really important skill. I've even heard that they call Hopkins the Emory of the North. So, so it's really, really important, that role. But I think the other role that academic institutions can play is that we have the capacity, first of all, we have easy access to a young population, right? There are constantly new students coming in. And what that speaks to is the need for capacity building. Mm-hmm. So, part of the conversations earlier today have been around this old school mindset that we have about what a refugee camp is supposed to look like and who refugees are, and how we need to shift that thinking. And so one of the other ideas that's kind of tagged on to that is that these disasters, complex humanitarian emergencies, or disasters, whether they're man-made or natural disasters, are rare occurrences. And so actually what we realize when we think about the current context, if we think about Ebola last year and Syria going on 6 years now, is that actually these things happen all the time. Mm-hmm. Haiti also 6 years ago, Zika right now. So we're kind of constantly facing these kinds of crises. At the same
time...
So
you're not differentiating between crises that generate refugees, natural disasters, epidemics. As far as you're concerned, when a mass number of people is involved, we should be concerned about that.
Well, when we think about complex humanitarian emergencies, what we're talking about are problems, whether they're natural or man-made, whether it's an earthquake or a typhoon or a conflict, that results in a system being overwhelmed. And so the same is true if we think about Ebola and the West African countries having healthcare infrastructure that was not able to deal with an Ebola outbreak. And the same is true with the Syria crisis. We've heard about the deterioration and, in fact, the targeting of healthcare professionals in Syria. So in that sense, they are very similar. At the same time, when we think about global health needs, what we are looking at right now is we're looking down the barrel of a gun in terms of healthcare professionals. So for many years, we've been hearing about the brain drain from the south to the north, where the northern countries were kind of stealing doctors and nurses to come fill their own healthcare systems. Well, actually now it's worse than that. We have a global workforce shortage of healthcare professionals, not just doctors, not just nurses, but also epidemiologists and other public health professionals. So coupled together, a kind of increasing trend or increasing numbers of disasters and these kinds of incidences with a huge gap in healthcare professionals, and the role that educational institutions can play is trying to fill that gap. And the way that we do that is by capacity building or training of public health professionals. So that's a role that Emory in particular, our Center for Humanitarian Emergencies, that we try to fill in partnership with folks at CDC to try and build capacity for humanitarian responders. And that's why it's especially troubling when we hear about targeted attacks on public health professionals in the Syrian context. We need to build capacity at the local level, certainly, but also on the global level, so that when there is this kind of crisis, we have the ability to be able to respond, and we have a core. And we saw that as an issue in the Ebola crisis, that we don't have enough French speakers, French public health speakers, to go out and respond to Ebola. And so when we're talking about not having a single cardiologist in Syria, not having a single pediatrician in Syria, having one psychiatrist in the country of Liberia during the Ebola outbreak. These are severe shortages, and we're going to see this more and more unless we do something drastic to respond to capacity building. So in that sense, I think that every educational institution, and I know there are many represented in this room, in Metro Atlanta certainly, there's a role to be played there in terms of preparing more professionals in this area. The other important role that I think that educational institutions can play is that because we are not government actors, and because we're not necessarily at the funding whims of government donors, we have a lot more ability to speak freely about some of the problems that we see. And so kind of being unrestrained in speaking about some of these issues in highly political contexts.
So anything you'd like to say about HHS right now?
HHS is doing a great job. Okay. But I think, what I'm thinking of more specifically is we can think and going back to Daniel's point about how we're all connected, the politics of this crisis is everywhere from Turkey, where basic humanitarian principles and human rights principles are being violated, where we have people coming in, seeking assistance, seeking help in desperate need, and being literally turned away. I've heard stories of people having arrived in Turkey and literally having been sent back, right? That's a basic humanitarian principle that is not to be violated. But we can also look in our own backyard, and we can think about Georgia in particular, and what kind of welcoming community do we want to be? We have a judge here in the Atlanta circuit who has a over 98% denial rate for asylum seekers. 98% of cases denied. So we have to think about the ways in which we're all connected and the ways in which the local connects to the global. Do we want to be a country, a place where we are welcoming to refugees, welcoming to asylum seekers? And those are different categories. So there's a lot of semantics around migrants and immigrants and asylum seekers and refugees and how those things are different. Do we want to be a community that welcomes those folks, or do we not? Mm-hmm. And how do we act accordingly?
Who studies with you? I mean, do all medical students study with you, and nursing students and public health students, or only those who want to? I mean, as somebody who's not in that field, I mean, how does that work? And Tom Kirsch left, the gentleman from the Emory of the North. I mean, what happens whether it's at Emory or Morehouse or Johns Hopkins? What kind of students should be learning to prepare for there's a word you used, unmitigated disaster or something like that, for these terrible natural, whether they're man-made or natural disasters?
Well, certainly, I think, from my opinion, this is training that I would hope that many people in the helping fields would be interested in, that those entering into the helping professions, which are many healthcare professionals, would be interested in pursuing this kind of work. Certainly, not all institutions require this kind of training. So I think that people
Should they?
Perhaps they should, and that speaks to the role of professional organizations. But I think even more broadly than those that are interested in, for example, working for NGOs, nonprofits or non-governmental organizations, even if you're not a clinician who says, yeah, I want to go to that disaster, right? Because there's a little bit something, I'm just going to be brutally honest, something a little bit off about humanitarians. Because it's like firefighters. Most people, when they see a building on fire, they run away from the building. But firefighters run into the building. And humanitarians and many health professionals are also that way. When we hear of an earthquake in Haiti, when we hear about hundreds of thousands of people showing up on the shores of Greece, we have something inside of us that says, I must go there. And that is not the reaction that most people have. However, even if you're somebody who says, no way, you couldn't pay me $1 million to go there, guess what? The world is connected. And if you don't go there, they're coming to you. And so from that perspective, every doctor, nurse, clinician that's going to come in contact, anybody working in an ER or a primary healthcare clinic could very easily come in contact with a refugee living in our own country that's had some of these experiences. And so the question really becomes, what kind of skills do those people need in order to serve and meet the health needs of the populations that they're serving?
That's great, thank you. Dr. Kim, how do you want to react to that?
Yeah,
when you were in medical school, did you study to prepare for these huge disasters like this?
I think that actually was more part of my public health training. I think we covered it a little bit in medical school, but there's a big push now in HHS to promote CLAS standards, which stands for culturally and linguistically appropriate care. And that's something that I believe every health professional or anyone in any helping profession needs to subscribe to. It's difficult or perhaps impossible to be a cultural expert in every single culture there is. So there's this approach of cultural humility. You know what you don't know, and practicing trauma-informed care, where you recognize that people may have had all sorts of traumas throughout their lifespan. And trying to avoid stigmatization of patients. When you talked about the mental health care needs of refugees, we're just careful to not paint every refugee as being, every refugee by definition has gone through trauma, but I wouldn't want to say that every refugee is traumatized and helpless or paralyzed. They are resilient and can overcome. Certainly there's people who could benefit from specialized care, but a lot of the needs of refugees can be addressed more through social connection and integration into communities. I also was reminded of talking to a refugee, actually a Somali refugee here in Atlanta, who commented that her negative interactions with healthcare professionals who did not recognize or give due respect to her experiences. She had gone through FGMC, female genital mutilation cutting, and the first physician she saw in America was very dismissive, basically just said, oh, you guys are all cut. And she felt humiliated by that comment. Obviously that physician did not have culturally appropriate skills. She then commented that the next time she didn't see that physician again, but went to a hospital in the area, and the attending noticed her condition and then invited a parade of medical school students to come look at her without consulting. So she felt like a specimen. She felt, obviously disrespected. So that's just an example of how at the very least, healthcare professionals need to be more sensitive in dealing with people from all sorts of backgrounds and experiences and practices. So,
JD, how is the state of Georgia government and municipal governments here? How are we doing with regard to refugees, the integration of refugees? How welcoming are we?
Oh, thanks for asking. No, certainly there is somewhat of maybe a difference between some of the rhetoric that we hear in the media and what is actually occurring in the communities. The Georgia community, specifically the Atlanta community, can be and is very welcoming to all types of diversity, including refugees. It has been a little bit of a difficult year nationwide in this conversation. It has gained we've been having a national conversation about it, whereas it used to not be very well known subject at all. And I'm happy to report that even though the conversation has broadened and we're hearing a lot more about it and there is a lot of negativity in the rhetoric, that it still is a vocal minority that's being outspoken with the negativity. And we are countering it in the local communities as well, and local communities are very supportive. Georgia is an interesting case study in that a few years ago, you would have identified Georgia as one of the top 5, maybe even the top 3 states where negative state level refugee legislation would have come from out of the State House. Certainly introduced, very well possibly passed. And in the past year, there was no negative refugee legislation in the Georgia legislature this year, in the Georgia General Assembly. However, in multiple other states where you wouldn't have guessed that there would be negativity, it has proliferated. And there are about 50 pieces of state-level negative refugee legislation floating around state houses throughout the entire country right now, unfortunately. Georgia is not one of them for one more year. Every year we go into it thinking the possibility that this year is the year that we'll have to counter that type of negativity. So what we'll see in 2017, I'd like to remain optimistic.
Dr. Kim, obviously you can't criticize state governments. Maybe you can, I don't know. But where legislatures and governors have said, we don't want refugees in our state, in real practical terms, what does that mean for your office in the Department of Health and Human Services? Does that mean if State X says we don't want refugees, you don't send them there?
Well, states don't, they can't really control who immigrates or come into their states.
It's a federal function.
Yeah, it's a human right to move where you want to move to as well. Even in refugee resettlement, if you are resettled in one place, hopefully it's a good choice and it's where your family and resources are. But if you want to move to a different state to pursue other economic opportunities, it is your right to do so. And it's one of the freedoms of living in the U.S. That we can go where we choose. ORR, the Office of Refugee Resettlement, did release a policy letter to states about discrimination with resources on federal resources if there are institution or actors or different organizations that are discriminating on the basis of national origin. If you're refusing to serve someone because you're from a particular country, that's not legal.
Mm-hmm. But does it impact your programs when you have a state say we don't want refugees, or does it deny
Well, there are
state services to refugees?
I mean, there are different models of refugee resettlement throughout the U.S. Most states, it's a state-administered refugee resettlement program, but there are, I believe, over a dozen states that have opted into what's called a Wilson Fish model, where the state
I'm sorry, say that again, the what model?
Wilson Fish.
Okay.
It's a model where the state has actually opted out of being the lead in refugee resettlement, or sometimes it's a mix, and a nonprofit organization, usually a VOLAG, a voluntary agency, has taken on the role of the state, as it were, in coordinating refugee resettlement in that state. So, it's an alternative model, and there's successful examples of it in the dozen or so states that implement that. So, even if a state does opt out of refugee resettlement, refugees are still going to be resettled there if they're affiliates. It's just that the state, can decide that they no longer want a role in coordinating that.
Dabney, is that one of the things you look at? I mean, academically, the reaction to refugees, whether it's the United States or Australia or Finland, for that matter. Is that an area of academic study? What causes that? What's the reaction to that?
I think that discrimination is a huge issue, and we can think about that in lots of different ways. But at the community level, which I think, as JD pointed out, is oftentimes very different from the ways in which we may see discriminatory policies at the state level. So, for example, a state might not be able to say, no, you can't come here, but there can certainly be ways and policies that can be set up that are not welcoming. And so we can think about that. I think, again, there's a mind shift that's required, which is there tends to be this perception that refugees are going to be a burden on the community. But what we've just heard is that here in Georgia, 90% of the refugees that are arriving here within 6 months are not only sustaining themselves, but they're actually contributing to our economy. And so, I would just ask us to think about it, and I won't say, every time you look at your iPhone, remember that a Syrian refugee designed that iPhone, but maybe every time you eat an ice cream cone this summer, remember that what would you do without that ice cream cone? Because you look at your iPhone all the time, and you're probably not going to think about it if I tell you to think about it then. So we need to start shifting our mindset and thinking about refugees as assets to our communities rather than drains or burdens on our communities. And so I think that there are a number of services, many of which IRC and other organizations provide to kind of set people on a pathway towards success. And I'm reminded of the comic George Carlin. I won't be as eloquent as Dr. Frieden quoting Einstein, but George Carlin said about the American dream.
You spent your time.
No, but the American dream, they call it that because you have to be asleep to believe it. So, think about what the American dream means now. What does that mean for people coming to this country? Because we are talking about people who are literally, coming off a plane from Hartsfield. They've already won the lottery, right? Because they're here. They get the shot, right? And so for me, what this begs a question of is about, again, thinking about systems change, which is we cannot be surprised when these things come up. And in the same way that you're asking about what are the special health needs of refugees, we also have to think about what are the health needs of our own population? Because if we're going to talk about UNHCR paying for national health insurance for refugees, that means we need to think about having a healthcare system that works in this country, right? And we don't have that. So again, it's the connection thing.
It's a little bit beyond the purview of this conversation
I don't know.
today.
I don't think so.
Maybe not. JD, what you're describing are people who have particular drive and grit. Is that fair?
That's a great term. That's a great term to use. Yeah, and specifically, they've won the lottery, as you said, and they recognize that, and they do not waste that opportunity at all. They take full advantage of it, and I see it every day, and I'm still just consistently amazed at how well that they just the assumption that there's just this ongoing cycle of poverty, and I regularly see it broken at least within a generation, if not within three to 5 years. It's just incredible to watch.
This has been great. We're going to open the session to questions from the audience, and hopefully the people with the microphones are out there circulating around. So if you, Maringo, I jumped you there before you held up the sign. So if we've got a whole bunch of hands up here, if somebody's got the microphone, and Alicia has got the microphone, and you get the first question. Tell us who you are.
Hi, my name is Miriam Witt. I work in supply chain and sustainability.
Wait, and just one comment here before you start. To everybody who asks a question, please, it should be a question. Okay, so that means short and get to the question mark.
Absolutely. What are the criteria for refugee selection? What areas are they picked from? How does that work? From the millions of people, how do you pick 70,000 and bring them to the United States?
That's actually more of a PRM question.
Yeah, where's Simon Henshaw? Did he escape?
I thought maybe, with your work with the IRC.
These people deal with them after they've already been selected, but you must have an insight.
To it.
Yeah.
Simon would have done a much better job of giving the official answer. But refugees are primarily defined through the international definition of persecution. You're facing persecution. You have fled your home country. You have traveled into a second country. So you've crossed an international border. And you cannot return due to that well-founded fear of persecution.
You have a well-founded fear of persecution
Exactly.
if you were to return to your own country.
On the basis of some specific criteria that are fairly well defined.
And then there's a whole vetting process that was referred to. You have to, obviously not be a security threat to the U.S. There's medical vetting. And so there's a very long process. I think it takes, 2 years or something like that?
It depends on the nationality, but anywhere from a year to 3 years, depending on the nationality. It's important to note, we talked about it earlier, the hardest way, short of swimming, to get into this country is through the refugee program. It really is.
And just to give, to put numbers to the scope, we talked about winning the lottery. If you make it here to the U.S., of all the refugees in the world, less than 0.5% are ever resettled in a third country.
Not to the United States, but to any third country.
And the U.S. does take
We take
the
about
most,
half,
yeah.
about half of the total that's resettled each year.
Do refugees tend to have passports? When you leave your country, do you take your passport and your documents with you, or do they have to get reissued?
It depends. We have it depends on whether you're from a country that can issue passports in the first place. It depends on what you took and the circumstances of when you fled. Sometimes when we're talking to groups, high school groups or other community groups, imagine yourself having to flee in the middle of the night. Imagine, what you can grab in the middle of the night. First, obviously, you're going to grab your children. You're going to go. After the fact, did you remember to grab your high school transcript? Probably not. But when you come, you're expected to somehow produce that magically, or get it from a government that no longer functions.
Wow.
Yeah, so it kind of depends on where you're coming from.
That's great. There's more questions over here, Alicia.
Hi, I'm here with Friends of Refugees, which is a group out in Clarkston and east of Atlanta, and also associate faculty with Emory University. So my question is this, that what are some ways we can help teach or train more healthcare providers, knowing this shortage, in a way that is culturally appropriate for refugees in our local community, but in a way that also is empowering to refugees themselves to take charge of their own health and not just see it as a service, but to take that step towards self-sufficiency and thriving in their new community.
Dabney, I think that was directed at you.
I think there are probably two ways that I'd answer that question. One is thinking about non-traditional learning. So I'm thinking particularly of what we call massive open online courses, MOOCs. Some of you may have heard of these, things like Coursera, platforms like that. We used a MOOC platform last year when the Ebola crisis was ongoing. Some of you may have heard, aside from being the, Hopkins being the Emory of the North, for a while Emory was kind of called Ebola University, because you may have heard that we took a few patients. And And so what we did is we actually created a massive open online course about Ebola, which was targeted at public health and medical professionals in developing countries. And it was the first English language course of this kind. And so what our goal was to make publicly available and freely accessible information about Ebola. Things as specific as how do you don and doff personal protective equipment for Ebola. So we literally had community members. There was a nursing student from Liberia who subsequently came to study at Emory who had 3 members of her family infected with Ebola. And she was caring for them in her home. And what she did was, she didn't learn it from us, she figured this out of her own smarts, was she saw how in the ETUs, the Ebola treatment units, people were donning and doffing the protective equipment. And she got garbage bags. And she covered herself in garbage bags to take care of her mother and father and her cousin. And she lost one of her family members, but 2 of those family members survived. And more importantly, she did not get sick because she was able to use her own wits and figure it out by observing what was going on in the ETUs. So sharing that kind of information in a widely accessible way is really, really important. We were really, really pleased that over 35% of the people that participated in that course, of which there were 10,000 people, were from developing countries. And that course is still available. I invite you all to look at it. The other thing that I would say is to look at the example offered by CARE, one of the co-sponsors of this meeting, which, as we heard earlier, the term care package really came from a humanitarian response model when CARE was established, to literally drop care packages. And CARE has gone through an evolution, still including humanitarian response, but then adding development as well, which again is the continuum. So thinking about preparedness, response, reconstruction, prevention, and response. And then the other piece that CARE has added more recently to their platform, which is something that I think we could all take a lesson from, is rights-based approaches. And so that's what I hear when you ask about having people involved in decision-making about their own care, is where is the rights element of that? Where is the dignity piece? Where is the piece where people can say for themselves, this is what a life of dignity looks like in my community, and what are the ways in which we can include that in public health programming, development programming, response programming, humanitarian aid.
That's great. Okay, yeah, right here in front, this young woman.
Thank you. So I think a lot of the challenge behind...
First, what's your name?
Christina, I'm sorry.
Okay.
I used to work for a resettlement, a VOLAG resettlement agency. But I think a lot of the challenge with wanting to accept more refugees into the state is because there are limited resources. I know I worked for an agency and we're very under-resourced in resettlement agencies, and so is the healthcare system already. So my question for Dr. Kim and for JD would be, at the federal or state, or for JD, like the national level, what steps are being taken to increase those resources? Is anyone looking at expanding the time of support for newly arrived refugees, to expanding that Medicaid period beyond 8 months, or expanding resettlement period? Because we all know they need longer than that if we've been in that field. So I'm just interested in steps being taken to increase services to refugees already coming before we bring more.
Okay, good. So, expanding services?
I don't want to speak on behalf of Simon or the State Department, but I have no doubt that they continue to ask for more money from Congress on an annual basis. I have no doubt whatsoever that they are consistently asking for that and making a well thought out, coherent plan to describe the need of why they need that additional funding. It would be wonderful if there was a plan, and I have seen it slowly tick up over the years. That's taken a decade, and it doesn't really keep up with the cost of services and the cost of paying case managers and things like that.
Dr. Kim, are you looking for more money?
Always. It would be wonderful too if Georgia expanded Medicaid. I mean, not only for refugees, but for all the other Georgians who could benefit from that service.
There you go. Okay.
I told you it was connected.
It's all connected. It's all connected. Damaso, you've had a load of questions. I'm going to try to see if somebody else has got their hand up. Over here and over here. We've been favoring one side of the room. Michael, if you, there's right there. There's somebody waving their hand right behind you.
Right behind? Okay.
Yeah, okay.
Oladile, Refugee Health. Question for Dr. Kim and also for JD. Dr. Kim, you mentioned that mental health is still one of the greatest unmet needs from a health standpoint. Can you tell us a little bit about what you're doing at ORR? And I know, JD, you all have been very creative with that issue. Could you also address the issue of mental health?
Sure. As I mentioned, there's the domestic refugee health screening. We recently took a look at all the state plans that states submit to ORR to figure out at a nationwide level what are different states and localities doing in their domestic refugee screening. It looks like about half the states include refugee mental health screening or a component of mental health screening as part of that initial domestic screening. So half maybe doesn't sound like a lot, but one also needs to take into consideration that if you don't have resources or places to refer people or have that capacity built in or made those linkages, if you screen refugees and you find that many of them need referrals, what are you going to do? So, I mean, part of it is building the capacity before you can even screen systematically. One of the things ORR has done is just this past December, we funded a new technical assistance provider to provide mental health technical assistance on refugees for the nation to build capacity in communities. They'll do consultations with individual localities or states and try to help troubleshoot and identify ways that communities can, bridge that gap. And it's not an easy question. It's not just refugees. It's many Americans are also suffering from the shortage of mental health care.
Great. Somewhere else over here, right here in front. Then we're going to go to the student section, y'all. We've got students here from a number of universities and colleges, so I want students to be thinking of questions. Hopefully you're a student.
I am a student. My name is Carrie Hatfield. I'm an ICU nurse at Grady Hospital. I'm also a student of Dr. Evans at Emory.
Great.
I actually did my nursing training at the Emory of the North, and now I'm a student at the Johns Hopkins of the South. My question is this. We talked a little bit about capacity building. We talked about the necessity of cross-cultural learning and things like that. But what I really want to know is what is being done to train local health workers in developing countries. For example, the earthquake in Haiti destroyed the nursing school that was there. Most of the doctors and nurses died in West Africa during the Ebola epidemic. So what's being done in the humanitarian world to train the next generation of doctors and nurses?
I think that's for you. Yeah.
She wasn't a plant, I swear.
Right, this is your student.
And we can talk about this later.
Did she now get an A in your class?
She already had an A.
Okay.
But I would say, there are a number of initiatives, but I would say for the most part, and I'm thinking particularly of Ebola, we have some very large efforts for healthcare systems reconstruction. That's been the case with Haiti. That's also been the case now in West Africa, kind of after the fact response. And unfortunately, this highlights something which I think is very common, which is that we have a very short attention span, as we talked about earlier, and we don't want to think about these things for very long. And healthcare systems infrastructure is not sexy. I've never met a donor who says, I want to fund healthcare systems infrastructure. I've never met a donor who said, yeah, I really want to fund something that's going to save millions of lives in advance. It's a hard sell. And part of that is a kind of identity crisis that we have, I think, within public health, which is it's very easy. We all got up this morning, we all came here Many of us drove in our cars and buckled our seatbelts and got in roads that functioned and came here, and we all had lovely meals without once thinking about all of the public systems. Although for those of you that live in the city of Atlanta that had a boil water advisory over the weekend, you might have been thinking about that. But before Saturday, you weren't thinking about whether your water was potable or not. So I think this is a very common problem that we have. And I think that most of the response has been exactly that response, which is, oh, now we need to build a system. Now we need to rebuild a system, as opposed to having training capacity. And when I talk about capacity building, I'm talking about human resources as much as I'm talking about building hospitals and clinics. And actually, human resources are probably a more important part of that. So,
Good. Questions, students, questions? If not, Damaso gets it. Oh, wait, there's a woman in the back. But you need to raise your hand higher. There you go.
Hi, this is Gülcan Sabri. I'm from Georgia State University. I'm a PhD candidate at Political Science Department.
Great.
And I do study state responses to asylum crisis. So my question is, the earlier talking have been around like how welcoming the local community is towards refugees and asylum seekers, and how that there's this vocal minority that actually spreads a lot of negativity, but in fact, when we look at the numbers, refugees are contributing to the society, etc. So my question is this: what really affects states' decision to accept like 10,000 rather than 100,000 refugees? Because when we talk about limited capacity or limited resources, I think about these Middle Eastern countries like Jordan, Lebanon, or Turkey that are hosting 3 million Syrians with relatively very limited resources. So what do you think is what is your take on the factors that affect federal states' decision to take in certain numbers of asylum seekers as refugees, but not more?
Well, that's a question for Simon Henshaw, unfortunately, who's
It is.
left. I mean, Secretary Kerry announced we're going to increase the number of refugees next year over this year. And I guess we'd have to ask him what affects that decision. I assume, and I'm answering the question as the moderator, and I apologize, but I assume that's an assessment by the executive branch of how much traffic the body politic is willing to bear. Not whether it's a sufficient number or the correct number, but how much is politically acceptable in the United States. Would you agree with that?
I would.
Professor Evans?
I would say that's a highly political part of the process, you know, the total number, but also the selection of countries. So we actually have a quota system in this country where year by year we're setting, we will take X number of Syrians, for example, or X number from other countries. So that process itself is highly political. But the other part of that, I would say from the US perspective, is that we have had the luxury, I'll call it, of not having folks showing up on our doorstep. It's not that easy to get here, right? And for the most part, Europe has been kind of buffered from that until now, right? So we've always seen lots of people moving in lots of different directions, but for the most part, they've been moving to what we typically think of as neighboring countries, right? The first country that they arrive in, which are oftentimes in much the same situation, maybe not the same political situation, but oftentimes the same economic situation as their neighbors. And so we have really been sheltered from that, so to speak. And now here it is knocking on Europe's door and soon probably coming to call our way as well.
Why has Canada been more welcoming of refugees in the United States?
Justin Trudeau?
So that's the sole factor.
Well, I'm sure it's not the sole factor, but I mean, if we look at the conversations that are having in our election cycle right now about not just the refugee crisis, but also the way in which we feel about immigrants, the way in which we feel about, you know, children that were fleeing violence in Honduras a year ago, the way in which we react to that, I think that we see that, you know, we're not so welcoming to immigrants as we may have been in the past and as perhaps we would like to think that we are.
Okay, good. More questions? Yeah, right here, this gentleman, and there's a young woman here and a guy behind you with the blue shirt.
Hello, my name is Rafael Olavarria, and I'm a political asylum seeker from Venezuela, and I've realized that the USCIS cases take a lot of time, and sometimes that encourages some other people to make immigration fraud during the process. It's taken over 2 years in some cases. Do you think there's any, or is there any organization or government agency putting pressure on USCIS to resolve those cases faster? Is this a matter of budget, or is it a matter of political will on this case?
Okay, so the question, he's Venezuelan asylum seeker, it's taking forever.
The Department of Homeland Security
That's the
question.
Department of Homeland Security, which is not in the room.
I mean, I have heard they are trying to hire more and more asylum officers to adjudicate these cases nationwide, especially from our grantees in the Survivors of Torture program, of which the majority, well, like over 40% of those clients are asylum seekers. That we've heard that comment. It's an issue.
Yeah, and there was a young woman there.
Hi, good afternoon. My name is Jacqueline Ulrich, and I've actually worked with refugees in the metro Atlanta area for around 7 years. And so my question draws a little bit on what I heard earlier about the lack of resources, and then what was directed towards Dr. Kim about resources. And what I have seen has really been, in working with several agencies, that the stopgap has been not so much with the federal funding, but with the private resource development and in the agencies themselves. So I was wondering if maybe JD and Dr. Kim, if you could speak a little bit to what those promising practices are in terms of local organizations that are doing their own resource development, or anything else nationwide that you might have seen that's been particularly effective in health.
Do you do much private fundraising?
The federal government tends not to.
Well, lucky I'm here then, because I do. No, there certainly is the private fundraising, whether it be individual support, contributions in kind, private foundational support, corporate support is a giant piece. I would like to say we've been the majority of our budget. Unfortunately, it's not. About 70% of our budget is federal funding through one source or another, and the other 30% is the makeup from everything else. But the individual contributions, the private foundational grants are all extremely important to us meeting the needs of the program. And the federal funding, the way it's set up, is it requires a certain amount of match or fundraising support. It is not designed to be the sole source of revenue to provide the services that are needed for an effective resettlement program.
Let me broaden the question a little bit, JD. What can we, not the people who come, the speakers from afar, but those of us who live here, what can we do to help other than write checks? I mean, I assume writing checks is a good part of it, but what else can we do to make refugees more welcome in Georgia?
Yeah, no, there's a variety of things you can do, some of which require actually very little effort, but have quite a bit of output. One, and I have been known to stand in rooms full of people and actually call out the number of the governor's office, and feel free to, I won't do that here, but feel free to call him and let him know, and if you're from another state, it applies as well. Let your elected officials know that you support refugee resettlement, you support your community being welcoming and open, and that you support humanitarian funding, whatever that might look like. Certainly let Congress know, as well as your local officials and your state officials know that you expect your state, your city, your country to continue to be welcoming. As well as get involved.
How do we do that? Because Daniel talked about that earlier and the importance of it. How do we do that?
Yeah, definitely you want to get involved. Feel free. We've got resource table outside. If you're in the metro Atlanta area, we would love to connect you with a volunteer opportunity. I can assure you, if you're not from here in Atlanta, that there are opportunities wherever you live. You just need to seek them out. I can assure you that there are refugees just about in every community at this point after 30 or 40 years of welcoming refugees into the country. There is an opportunity to serve. There is an opportunity to be a good neighbor. Maybe sometimes that's just it alone. After a generation, refugee families don't necessarily self-identify as having come as refugees. You would just know them as the family that may not have been born here. But they're living right next to you, and they have 2 cars and a son and daughter in college, and maybe run a business.
Yep. Okay, we've got time for one more question, I think, or not. Okay. Oh, there you are. Good.
Hi, my name is Maria Guzman. I'm from Emory. I go to Emory University. And
wait a minute. What are the chances that 2 Venezuelans are going to speak in an audience in Atlanta today?
I think there are a lot of chances since we are spread everywhere. So my question is, from the 10,000 Syrians possible resettlement that the U.S. is going to have, how many do you think will come to Georgia, and how much money do you think will be needed to successfully provide all the resources needed, the integration, et cetera?
Okay, so 10,000 Syrians coming to the United States. How many of those will come to Georgia?
A proportionate amount that probably matches the same percentage. It's important to remember, specifically with the Syrians, we've talked about Syrians all day today, that we talked about Canada. Canada promised to resettle 25,000 Syrians in the fall. They've already met that goal and have exceeded it. The United States at the same time was talking about resettling 10,000 Syrians. We have yet to meet that goal. We haven't even met half of that goal in the 5 years since the war started, unfortunately. Political will, Simon mentioned earlier that we are going to reach that 10,000 goal. That would be absolutely wonderful. I am geared up to work all summer long to meet that goal, which is probably what it's going to take, and that will be fine. The unfortunate reality of the Syrian situation is that in the past year and a half, more Syrians have drowned than have been resettled into the United States in the past 5 years.
Wow.
So that is a particularly disturbing statistic, and that bothers me as a humanitarian, as a human being. It bothers me as an American. We can do much better than that. So hopefully meeting the goal of 10,000 will reverse that statistic, and we can also eliminate the drownings that are occurring and develop a much more a safer system for everyone to be identified and then for their needs to be met.
That's cool. And that's the last word. I want to thank you, and I want to thank the members of this panel, Dr. Kuri Kim, J.D. McCrary, Dabney Evans. Thank you very much. This has been terrific, a terrific conversation. Thank you. Whoa. And I get functions at the same time. I'm going to transition, and suddenly I'm the closing words. So I'm going to give you all some closing words. I mean, I want to thank all of you who've been here all day long, and I want to thank those of you who've dropped in and dropped out. But I, in particular, want to thank the speakers who have come from so far to participate with us. Paul, you were terrific, and I appreciate that. And we're going to send your slides to everybody. I think we've got everybody's email address, so we'll make sure they get those beautiful slides that you worked on. Steve, you've been a terrific partner in this, and I appreciate you helping us plan it and helping us execute it, and appreciate all that you've done. And I wish I were as good a moderator as you were. if you're interested in what's going on in the Atlanta area, just so happens that we have a program this Thursday night at the World Affairs Council, which is across the street over here, with Mayor Ted Terry of Clarkston, which is the municipality in Metro Atlanta which has, as I understand, I don't know if it's numerically correct, but certainly proportionally correct, has resettled the largest number of refugees in the metro area. JD, is that right?
Yes, sir.
Yes, sir. Okay, so that's right. So please come join us Thursday, May 5th. I'm fixing to say that. Hold on. Now, this is what we call a members forum. We have a members forum every month at the World Affairs Council. And as the name applies, the members part means it's for members. And if you're not a member, become a member so that you can come participate in this, because it is going to be terrific. And for the cost of today's lunch, you can join the World Affairs Council, and the lunch was free. So there you go. Everybody sign up and join. I think this has been an extraordinary experience for me personally. This is our 5th Global Health Summit. This is, and I haven't been at 3 of them, but I'm going to guess that this has been the most political of them, where we're not talking about disease that's caused by lifestyle or disease that's caused by poverty or disease that is infectious, but we're talking about a whole constellation of health issues that are related directly to our failure as human beings to deal with our disputes in a way that doesn't displace people, destroy their lives, and in this case, certainly focus on medical personnel. And that's a tragedy. I mean, it is an absolute tragedy. And you can't take the medical side of that, the health side of that, and separate it from the political side of that. It certainly is true in Syria, and I think it's true in everywhere else that we have been talking about over the course of the day. And that makes our responsibility that much heavier as individuals to what we can do. I thought it was interesting, people were talking about prevention. Dr. Frieden talked about that. You know, we talk about prevention with health issues. Well, if war, civil strife is a health issue, how do we prevent that, right? I mean, quitting smoking, that's great, is a way to prevent a whole series of diseases. But how do we prevent all these disruptions and trauma and interruption in treatment of diseases that are caused by this political strife? And that's something that we have to dedicate ourselves to, not we, the people in this room, but we in the much larger sense, to preventing this so that we can stop future Syrias from happening. So I want to thank you. I'm going to end on that. I want to thank our partners, CSIS and CARE. I want to thank all the companies who are listed as supporters and sponsors of this. I'm sure to forget some of them, but UPS and Coca-Cola, oh, good, they're all up on the wall there. The Robinson College of Business at Georgia State University, the CDC Foundation, Hartfield-Jackson International Airport, Hawaii Pharma, Morehouse School of Medicine, and I can't read the rest because my eyes aren't good enough, but y'all can. So I want to thank all of them. In particular, I want to thank the World Affairs Council staff. And Hina, stand up. Hina Rennie has been working on this for at least the last 3 months and probably longer. And so this has been a real tribute to her, and I want to thank you, Hina, for all the work that you've done. There's a whole bunch of World Affairs Council staff and volunteers, and again, if you would all raise your hands and wave a little bit, I want to thank you very much. Come on, you can raise your hand higher, Maringo. Come on, and I hope to see, I don't hope to, I plan to see you all Thursday night when we talk about Clarkston, Georgia, and have Mayor Ted Terry. So thank you all very much. It's been a great day. Thank you. Give yourselves a round of applause.